Welcome to the deep dive. If you're trying to build a solid three-dimensional understanding of, well, the most functionally dense part of the human body, you've landed in the right place.
We are taking on a huge topic today.
We really are. We're going to dive into the general structure, function, and surface anatomy of the abdominopelvic cavity. Our mission today is to move beyond, just static diagrams. We're going to try and synthesize a comprehensive mental map of this huge continuous space.
And focusing on how structures really relate to each other spatially.
Exactly, and how the nervous system controls this whole massive operation, and then how we can translate all of that complexity to landmarks we can actually feel on the outside.
And this really is the central station of the human body. I mean, you should think of it less as an empty box and more as the largest continuous visceral cavity we have.
Right.
It's responsible for housing and powering our digestive, urinary, and reproductive systems.
Yeah.
But it's also, and this is crucial, the body's main neurovascular highway.
The highway connecting the torso to the lower limbs.
The whole thing.
Yeah.
So it's dynamic, it's large, and it is complex. We really need to start by just understanding its borders.
Okay, let's unpack this, beginning with the container itself. The musculoskeletal framework that gives it its shape. And maybe more importantly, its protection. So if you're trying to imagine the container, the rear support structure is, well, it's pretty obvious. The 5 big lumbar vertebrae and their discs just running right down the posterior midline.
Right, and that structure is incredibly strong, but it also creates a subtle anatomical point that's easy to miss.
Oh.
If you were to look at the abdominal cavity in a cross-section, that big indentation from the vertebral column means the cavity isn't a perfect oval. It's actually described as being somewhat kidney-shaped.
So it's deeper in the back than you might think.
Exactly. It's a great little visualization cue to start with.
Okay, so that's the back wall. Now, moving to the front and the sides, the anterior wall is dominated by the rectus abdominis, the straight muscle running vertically.
The six-pack muscle.
Right, but the real bulk of the containment and the movement, that comes from the 3 layers of the anterolateral wall.
And those are the big muscular sheets.
Yeah.
The transversus abdominis, and then the internal and external abdominal obliques.
Their function is
Yeah.
layered, isn't it?
It is. It's triple layered. They protect the viscera, for one. They also create the force for trunk flexion, extension, rotation. And this is critical. They contain the pressure you need for things like coughing or a forced breath out.
And what about the roof and the floor of this massive structure?
The roof, superiorly, is that huge muscular dome of the respiratory diaphragm. And then inferiorly, the floor is made by this robust muscular hammock we call the pelvic diaphragm and the perineum.
I think a key insight here is the protection factor. We tend to think of the ribs as belonging just to the chest, right?
Yeah.
But anatomically, the inferior 6 ribs and their cartilages, which are technically part of the thoracic wall, they actually provide crucial protection for the upper abdominal viscera.
Shielding organs like the spleen and the liver. It's a great example of that sort of anatomical redundancy, how the body just blends systems together.
So now that we've built the container, we have to talk about the main traffic intersections, the high-speed highways where critical structures are exchanged.
And the first major one is the diaphragm itself, the thoracoabdominal interface.
Right. There are 3 main pathways here, and visualizing exactly what passes through each one is, well, it's critical for tracking vessels and nerves.
We can think of them by their vertebral levels. So high up in the central tendon, you have the caval foramen, roughly at T8.
And that's the expressway 4.
For the largest vein, the inferior vena cava, and with it, the right phrenic nerve.
Okay. Then moving lower, around T10, you hit the esophageal hiatus.
This path is really unique because it's encircled by muscle fibers from the right crust of the diaphragm, which makes it much more dynamic. It's not just a passive hole.
And it transmits the esophagus and, crucially, the vagal trunks.
Which are the main parasympathetic nerves for the gut.
Yep.
And finally, the lowest of the big 3, usually down at T12, is the aortic hiatus.
Oh, less muscular opening.
Much less. It's posterior to the median arcuate ligament, and it's the path for the aorta, of course, but also the entire lymph drainage of the lower body via the thoracic duct and usually the azygos vein.
So the diaphragm is really this critical choke point.
A gateway for every major system.
Okay, that covers the top entry points. So how does the plumbing and wiring get out the bottom? We move to the interfaces, linking the pelvis to the lower limb.
Right, and instead of listing every single structure, let's just focus on the main routes.
Good idea.
You have the main highway, which runs deep to the inguinal ligament. That carries the major femoral artery, vein, and nerve into the leg.
And then you have the big posterior exits, the greater and lesser sciatic foramina.
And if you only remember one thing about those, remember they transmit the body's largest nerve, the sciatic nerve itself, along with all the internal pudendal structures.
And the final route.
The obturator foramen, an opening that carries its namesake structures. The obturator nerve, vessels, lymphatics out to the medial thigh.
What's fascinating here is how the central control panel governs this entire huge volume. We're talking about the autonomic nervous system.
And the general rule is, well, it's actually pretty simple. Even if the pathways get incredibly complex, sympathetic signals are like hitting the brakes.
They inhibit motility, secretions, they clamp sphincters down.
And cause vasoconstriction, exactly. While the parasympathetic system is like hitting the gas for digestion, it's the rest and digest manager.
Let's break down the sympathetic system first, because its fibers have to travel a pretty long way. Their cell bodies start way up in the T1 to L2 spinal segments.
And they travel down to the abdomen through the thoracic splanchnic nerves. These are basically dedicated sympathetic highways.
So you have the greater splanchnic nerve.
Right, from T5 to T9. It enters the abdomen right through the crust of the diaphragm and targets the coeliac ganglion. Then you have the lesser splanchnic from T10, T11, and the least splanchnic from T11 or T12. All essential sympathetic inputs for the upper gut.
And it doesn't just stop there. As we move lower, the lumbar splanchnic nerves, particularly from L3 and L4, they become really important.
Extremely important, because they're the ones that feed down into the pelvis, contributing to the hypogastric plexuses.
And there's a clinical takeaway there, right?
A huge one. Injury to those lumbar splanchnic nerves is a known risk during complex aortoiliac surgery.
Why is that?
Because they're responsible for innervating crucial structures like the neck of the urinary bladder and the ductus deferens. So damage can easily result in sexual dysfunction. It really underscores the precision you need in that area.
Okay, so if the vagus nerve is running the show up, top supplying the foregut and midgut down to the transverse colon, who takes over parasympathetic control down below.
For that whole lower half, so the hindgut, the urinary bladder, and providing vasodilator fibers to the pelvic organs, we rely on the pelvic splanchnic nerves.
Originating from S2 to S4?
That's them, the sacral parasympathetic outflow.
And all these different fibers converge in these networks, these autonomic plexuses, like main switchboards. The biggest one is the coeliac plexus, right?
The biggest and the highest, yeah. It's at T12L1, wrapped around the coeliac trunk. And because this plexus also carries visceral afferent fibers, pain fibers, from the upper abdominal organs, its location makes it a target.
For intervention.
Exactly. A coeliac plexus blockade is a common way to manage really intractable abdominal pain, especially in patients with, say, pancreatic disorders.
Moving down that sympathetic highway, the control then shifts to the superior hypogastric plexus.
Which lies right in the center, just anterior to where the aorta splits. It's like a major data bus that gives rise to the paired hypogastric nerves.
And those nerves then descend into the pelvis and branch out to form this incredibly complex
inferior hypogastric plexus. This is like the local area network on the pelvic sidewall. It's where you get that final intricate mixing of sympathetic signals from above and the parasympathetic input from the pelvic splanchnics.
Let's shift gears from nerves to the blood supply. The vascular arrangement of the entire GI tract is. It's beautifully organized around a central idea.
Its embryological origin. That really simplifies the map.
So the three major unpaired aortic branches are sequential and pretty predictable. First, at T12, we have the coeliac trunk,
supplying all the foregut derivatives: stomach, liver, spleen, pancreas.
Second, typically arising a bit lower at L1 is the superior mesenteric artery, or SMA,
which feeds the entire midgut. That runs from the mid-duodenum all the way down to the distal third of the transverse colon.
And third, the final major branch, usually at L3, is the inferior mesenteric artery, the IMA.
And that supplies the hindgut derivatives, the rest of the colon, and the proximal anal canal.
The really crucial takeaway here isn't just the list of arteries, though. It's the redundancy that's built in.
The anastomosis. The connection between the SMA and IMA territories, known as the marginal artery, is a critical backup system. If one major artery gets blocked, that connection can keep large sections of the intestine alive.
Okay, so if the arterial system is the highly pressurized delivery truck,
then the hepatic portal venous system is the unique collection and processing system. It's defined by connecting two capillary beds, from the GI tract organs to the capillary beds inside the liver, the hepatic sinusoids.
So the main hepatic portal vein forms from the convergence of the superior mesenteric vein and
the splenic vein. And you should picture this. The meeting point is usually posterior to the neck of the pancreas, right around that L1 level.
Aligning with that important transpyloric plane we'll get to.
Exactly. And as it ascends toward the liver, it has very specific spatial relationship. It's positioned posterior to the hepatic artery and the bile duct. One last detail. Unlike most veins, the portal vein in adults has no valves.
So now we have to zoom in, like dramatically. We've seen the major highways and the control systems, but what's really fascinating is how the GI system manages its own traffic control internally. And to see that, we have to look past the vessels to the microscopic architecture of the GI wall itself.
And every hollow abdominal organ shares a common structural plan. You can move from the inside out in 4 main layers.
The innermost is the mucosa, the layer of immediate contact doing secretion and absorption.
Then you have the thick, strong submucosa, which is highly vascularized connective tissue. And next is the engine room, the muscularis externa.
Inner circular and outer longitudinal smooth muscle layers, the ones that generate peristalsis.
That's it. And finally, the external layer is either the serosa, if it's covered by peritoneum, or adventitia if it just blends into the surrounding tissue.
The key to function here, though, is the intrinsic control system.
Yes. We rely on the interstitial cells of Cajal, or ICCs. You can think of them as the GI tract's electrical pacemakers.
So they're generating the rhythm.
They generate these slow waves of rhythmic activity that propagate through the muscle layers, basically igniting peristalsis. Defective ICCs are strongly implicated in motility disorders. When the pacemaker fails, the whole rhythm breaks down.
And controlling that pacemaker is the enteric nervous system, the ENS. It's often called the body's second brain.
Because of the sheer density of neurons, yeah. And this system forms 2 main plexuses. The main motor control center is the myenteric or Auerbach's plexus.
Which is located where?
Between the circular and longitudinal muscle layers, it manages contraction and relaxation, and it runs continuously from the esophagus all the way to the anus.
And the second plexus?
The submucosal, or Meissner's plexus, found mainly in the intestines. This one focuses on managing the local environment mediating mucosal absorption and secretion. So the extrinsic nerves we talked about earlier, they don't drive digestion directly.
They just modulate the activity of these 2 intrinsic plexuses.
Is it?
After all of that internal complexity, I find it amazing that clinicians can translate all those tiny nerves and vessels to just a few key points we can feel. So here's where it gets really interesting. Surface anatomy.
And you have to remember, every individual is different, so these levels are always approximations, but they're critical for reference. We can make a little checklist of vertebral levels starting high up.
Okay.
The ziphisternal joint is usually T9.
And moving down, the single most referenced horizontal line is the transpyloric plane, typically at the L1 vertebral body.
And this is such a crucial plane because it marks the neck of the pancreas, the heel of the kidneys, the origin of the renal arteries, the duodenojejunal flexure. It's the abdominal center line.
It's a busy intersection.
It is. Then we hit the supracrystal plane, or Tuffier's line, which joins the highest points of the iliac crests. This line is commonly at L4.
And why is L4 so critical?
It's the level of the aortic bifurcation. That makes it the surgical safety checkpoint for a lot of lower lumbar procedures.
And just below that, the inferior vena cava is formed at L5. These are like non-negotiable landmarks.
They really are.
We also have to mention the soft tissue landmarks. While the umbilicus is highly variable, it's still the central reference point, usually around L4 in a supine adult.
And in laparoscopic surgery, knowing the surface projection of the inferior epigastric artery is a matter of absolute safety.
Right.
Because it runs along the medial border of the deep inguinal ring, the rule is to insert instruments laterally to avoid slicing it.
Okay, let's talk practical application. This mapping guides clinical procedures. For example, when creating an intestinal stoma, why do surgeons favor transrectus incisions, splitting the muscle fibers?
It's all about biomechanical support. Using the muscle as a collar provides a dynamic contractile surround for the stoma. It significantly reduces the risk of peristomal herniation.
And for something like a suprapubic catheterization, the access point is the midline, through the distal linea alba.
But it only works when the bladder is filled and has expanded up above the pubic bone. That ensures you don't hit other structures on the way in.
So what does this all mean? We've achieved a pretty comprehensive synthesis today, I think. We went from the solid musculoskeletal frame through the neurovascular highways, zoomed all the way down to the enteric nervous system.
And then connected all back to the surface landmarks that translate all that knowledge into clinical action.
We've built a cohesive understanding, moving from the large-scale L4 aortic bifurcation all the way down to the microscopic role of the interstitial cells of Cajal.
Right. But to leave you with a final thought to mull over, this foundational anatomy is still being explored. For example, the traditional view is that the sacral autonomic outflow is purely parasympathetic.
But
But some recent experimental studies suggest it might actually share a common sympathetic identity.
which just emphasizes that anatomy is not this static subject written in stone. It's still being explored and redefined.
All the time.
Use this synthesized map as your guide. Thank you for joining us on this deep dive.